So for both of them, use abnormality to determine are there any difference between the exposed or in the control individual, or between patient and non-patient, right? Now, so there's a protocol. So for example, chromosome. So you know, the chromosome, we detect this abnormality, deletion, balance translocation, dicentrate, or chromatic break, and so on. So they are very clearly defined. Obviously, they are abnormal repair. Otherwise, they would not be like that, right? This is a lack of repair, right? Abnormal repair, abnormal. So this is clearly a detection of abnormality in repair process. So people with a lot of this abnormality would certainly indicate they don't repair the damage well. So the irradiation is very standardized. Everybody is irradiated the same way. So we compare different people, different population, to identify how well they repair DNA damage. Next slide. So we can also use a COMET assay in the challenge COMET assay. So we can grow the cell like lymphocyte, irradiate it, and spread them on the slide for COMET assay, or we can expose animal and then do the challenge assay. So these are two different ways: COMET operation or challenge assay. But we found that the COMET assay is much easier to do and more readily useful for quantitative determination. The next slide. Right. So we have published a lot of papers from my own laboratory, from collaborator in Poland, Czechoslovakia, Italy, USA, China, Thailand, Egypt, and so on. Right. So this is a brief summary of the work presented using the challenge assay. So significantly abnormal DNA repair capacity have been reported in cigarette smoker, resident exposed to uranium mining waste, this is radiation exposure, worker exposed to butadiene, lead, mercury, pesticide, xylene, and high level of environmental pollution. Also, their report showed that there were normal repair capacity in worker exposed to low doses of butadiene. This is high dose of butadiene, the low doses. It's interesting. It makes a difference. I mean, the assay is sensitive. And in women exposed to general environmental pollutant compared to heavy environmental pollutant. These are radiation exposed pollutant. So a lot of these studies have shown that the challenge assay is useful in population study and in identifying DNA repair capacity in exposed individual on an individual basis, right? So next slide. So based on this study, we developed, the collaborator and I developed an equation that can quantitate DNA repair capacity. So this is based on a COMET assay. R0 will present DNA breakage level immediately after irradiation or after different challenge agent. R20 for the COMET assay is 20 minutes later, its DNA breakage level after 20 minutes of X-ray induced damage, or 60 to 100 minutes after UV light. So we have this condition worked out, times 100. So in that case, then we have a quantitative determination of a single person repair capacity based on our assay. That's very important, not on the group, but as a single person. We can repeatedly analyze it to get a similar result. So that repair capacity is representative of that particular individual. Next slide. Right. This is a summary of the data from pesticide exposed workers. Right. So this 0 is normal repair. This plus 10 and minus 10 is plus 5 and minus 5, the standard deviation. of the normal population. So each bar will represent one worker. You can see from this slide, most of the workers have worse repair compared to the normal population. There are some variation, but most of them have less. And maybe one of them is better repair than the normal range. But that is very unusual. Maybe that one is very efficient in detoxifying pesticide. Well, it's good to know. Yeah. Now, so from this study, we can safely predict that these individuals, this and this, are at the highest risk for disease from exposure to pesticide, and may as well from exposure to other toxic substances, because they do have very poor repair capacity as compared to rest of the worker, as compared to normal population. So this is important data. So now you can see that it is individual basis. Next slide. Yeah. Well, so the pesticide is a prediction. We did not do the follow-up to see whatever happened, but we did other study with follow-up to identify the outcome. So the question is, can repair capacity predict an individual health outcome? So we did other study, a study with cancer patient, and or exposure with associated with clinical outcome. So these are outcome measurement. And so I would present to you our report based on this one. Next slide. All right. So we did a study on breast cancer patients. So breast cancer patients were recruited before therapy and were studied for their DNA repair capacity. So from our breast cancer patient, their real repair capacity quantitated as a group, kind of 40.2 plus or minus 33.1 repair capacity, compared to matched female normal control, 52.6. So these two are significantly different from each other. That means the cancer patient, even before therapy, have less repair than normal female. So this may be one of the reasons why they develop breast cancer, right? So of course we need to study, and also important part is that we study the patient, none of them have the BRCA mutation in the gene. So these are not BRCA mutated patient. There's a normal breast cancer patient. So that we're the first one to identify that they do have DNA repair deficiency. Well, so look, go back, please. Thank you. Go back. Yeah. So among the patients, some of them have lower repair than others, just like the pesticide exposed population. Some of them are worse. So, but in cancer patients, we can make an association with outcome, because we find out that those with lower repair capacity have poorer prognosis. So these people have lymph node invasion and metastasis. That means the DNA repair capacity as detected in lymphocyte also identify that they do have poor prognosis. You know, the cancer cell, it can, with that capacity, can survive and cause more serious problem than otherwise. All right. So this clinical study allow us to make a window of prediction and verification of the outcome. Next slide. So now we can go, we have done another series of studies on benzene with collaborator to determine the health risk. Next slide. We know that benzene is a human leukemogen and a myelosuppressor in the bone marrow. So, and the leukemogenic effect has been detected if population has been exposed to more than 100 parts per million based on epidemiological study. Based on the biomarker study, the population of workers exposed to 25 parts per million show chromosome breakage. Right? So these two are confirmation that exposure to benzene is hazardous and can cause health problems. So from this, the occupational exposure limit has been set to be 1 part per million. So as compared to the data of 100 and 225 parts per million. So the question is 1 part per million safe or not? So in our environment, we do have benzene also in the environment because they come from gasoline. So there may be 1 part per billion compared to 1 part per million. So the question is the same also. Now, I also want to make emphasis that this epidemiological study and biomarker study identify these as hazardous level, but these are much higher than the exposure limit, indicating that these studies are useful but not very sensitive because we will not be able to detect hazard with 1 part per million exposure. We need to use better assays. Now that's why we do investigation. And I'll share with you some of the new investigation. Next slide. Now, so this is a summary of ongoing summary of the report that benzene exposure causes a dose-dependent biomarker effect. I mean, lower exposure may still cause effect, but we need to find an assay that can detect the effect. So toxicity have been observed in worker with exposure below the current exposure limit of 1 part per million. Polymorphism of certain gene is associated with bone marrow toxicity. So the question is, can we do functional study to fine-tune the risk prediction and provide individual risk for health effect? Okay? So we need to identify better marker and more sensitive and functional biomarker for more precise risk assessment and disease prevention. Next slide. So with my collaborator, we did the study of benzene exposed workers, exposed poison worker, exposed worker, and cell exposed in vitro to benzoquinone. So these benzene poison workers indicated that they have been exposed to high doses, and they are also highly sensitive to the exposure. The assay include micronuclide assay, mRNA, microRNA, the challenge assay for DNA repair capacity, biological pathway analysis. The result from this study indicate that the population who are exposed to less than 1 part per million benzene and increased micronuclide, increased expression of microRNA 222, reduce DNA repair capacity on the individuals and have and show these also associated with bone marrow toxicity. Next slide. This is a summary of the report I mentioned to you. So from cell culture, the cell were exposed to benzoquinone, as you know, is a known toxic metabolite of benzene, to show that they induce abnormal microRNA expression, leading to perturbation of the MDM2 pathway, which interact with the p53. So with cell culture, this was established from the evidence. So these, I mean, they would affect cellular function and respond to benzene toxicity. Right? So from exposed workers, our study identified they had increased micronuclei and they have DNA repair efficiency in DNA repair capacity